Hi, I'm Amy Bax, lead author on the recently published paper in the Journal of Developmental and Behavioral Pediatrics exploring the associations between race, ethnicity, and socioeconomic factors among children with ADHD. And in general, research for the past 5 decades has explored thoroughly whether or not any demographic factors may be related to ADHD diagnosis and treatment in children. However, the results have been largely inconsistent. This is thought to be in part to how the ADHD diagnosis is obtained in the study's design. Several studies use simply a parent report of ADHD diagnosis, while others use a more rigorous case definition based on DSM criteria obtained with reports from parents and teachers. And we pose the question of whether this difference in parent report versus case definition criteria could have some reflection of whether children have had better access to a clinician and gotten a diagnosis per parent report, while the case definition might reflect true underlying ADHD. Our study analyzed data from the Project to Learn About ADHD in Youth, which was funded by the Centers for Disease Control and Prevention. We were able to do secondary data analysis on 1,068 elementary school-age children from 5 school districts in Oklahoma and 1 large school district in South Carolina. We had particular interest in looking at various race, ethnicity factors, socioeconomic factors including income and health insurance status, family structure, sex, and geographic location. We were looking specifically at parent-reported ADHD diagnosis, parent report of ADHD medication use, and the PLAY study's case definition, which did indeed use DSM criteria obtained from parents and teachers on all participants. Overall, our study showed that there was a 10% rate of parent-reported ADHD diagnoses, with 8.8% children taking ADHD medication and 8.3% of participants meeting criteria for the PLAY study case definition. Using our multivariable model analyses, so all factors considered at once, there were no differences in terms of effects related to geographic location, but we did find key findings in looking at SES, race, ethnicity, family structure, and sex. Specifically with SES, we saw that children with Medicaid were more likely to be taking ADHD medication than children with private insurance or no health insurance. And we also went the extra step of looking among children who met case definition criteria for ADHD. And in that group, children with Medicaid were more likely to be the ones who had gotten an ADHD diagnosis. And this was also relatively similar related to higher family income. In terms of race ethnicity findings, like many past studies, white children had higher rates of accessing a clinician to receive ADHD diagnosis and medication based on parent report. But when we looked at who met case definition criteria, which may better reflect ADHD prevalence, there were no race ethnicity differences except that Hispanic children had a lower prevalence rate. This could suggest that that gap previously seen between white and black children is narrowing. In terms of sex differences, like most past studies, boys in this analysis had much higher rates of truly meeting ADHD case criteria and accessing a clinician to have received an ADHD diagnosis and medication. But we found a relatively new finding in that when we looked at the children subgroups who either met case definition criteria or did not, actually among the case negative group, boys were far more likely to have gone to a clinician and received an ADHD diagnosis than girls. And we really didn't see that finding among those who were positive for ADHD. So might this suggest that boys are having higher false positive rates of ADHD? This is a question that warrants further explanation or exploration. Similarly, in children from single parent households, we saw that they too had higher rates of meeting ADHD case definition criteria and accessing a clinician to receive a diagnosis than parents or children from two parent households. But just like the sex difference, among the case negative group, children being raised in single parent households also were more likely to have been taken to a clinician and received an ADHD diagnosis. It's possible that some of this is because children were on medication, but the effect doesn't seem to be entirely explained by that. So again, this warrants further study. In conclusion, we saw that children who were white, children with Medicaid, those that are boys, and children being raised in single parent households are all more likely to access a clinician to receive an ADHD diagnosis and treatment. We did find that Hispanic children seem to have a lower prevalence rate of ADHD, but a rather new finding was that among children who did not meet criteria for ADHD, boys and those from single parent households seem to be more likely to have possible false positive ADHD diagnoses. And we're excited to explore these factors further, and we encourage others to do the same. I want to thank everyone for tuning in to this presentation.